Good morning, everyone, and thank you for joining us today for today's institutional conference entitled Important Aspects of Stroke Imaging, a detailed look at CT scoring in acute stroke. We're thrilled to have you all here. I'm Dr. Joseph Alfonsi Atienza from the Department of Radiological Sciences.
And I'm Dr. Cristel Catherine Serrano, and we will be your hosts for today. Just a few reminders for this event.
Please mute your microphones, and if possible, kindly turn on your video cameras.
Please reserve all questions at the end of the presentation. Alternatively, you may write your questions in the chat box.
Do not leave the meeting until the end of the session.
And please answer the post-quiz for the attendance.
To begin our program, may I invite everyone to calm our hearts for the opening prayer.
Let us put ourselves in the holy presence of the Lord. Heavenly Father, as we gather here today for this institutional conference, we pause to express our gratitude for this time and the opportunity you have given us to expand our minds and grow in understanding. Bless the speaker with clarity and wisdom, and help each of us to be attentive, open, and very eager to learn. May the lessons we receive today inspire us, strengthen our minds, and equip us to serve you better and those around us. We offer this time to you and ask for your grace and blessings on all that we do. In your holy name we pray. Amen.
Now we proceed with the singing of our national anthem.
Bayang magiliw, perlas ng silanganan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupit, di ka pasisilil, sa dagat at bundok, sa simoy at sa langit mo bakaw, may nilang ang tula at awit sa paglayang minamahal, ang kisap ng watawat mo'y tagumpay na nagdidinig, ang bituin at araw niya kailan pa may magdidilim, lupa ng araw ng maraming pagsikat, buhay ay langit sa ating mo, aming ligaya na pag may mamating, at mamatay ng dahil sa'yo.
To formally open our event, we would now like to call on our dedicated Medical Center Chief, Dr. Evelyn Victoria Iriside, to give the opening remarks.
A pleasant good morning to everyone. I would like to take this opportunity to congratulate our Department of Radiological Sciences for coming up with this very relevant session for this month's institutional conference. I cannot emphasize anymore how much we have been pushing universal healthcare among our staff and also among our colleague DOH partners. And I would like to think that this is again one of our key contributions to uplifting our services, not only among our staff, but also among our partners in other institutions. Neurologists and radiologic technicians and radiologists are not very common in far-flung areas of the country. And so to have such pearls to guide us in the management and diagnosis of neurologic conditions will be very, very welcome in these geographically isolated and disadvantaged areas. And so to learn from one of our own, and that is always a gift for our mentors, not to see our mentees rise up and to take their place in our in the landscape of our hospital and beyond. No, we are definitely very proud of this session. So congratulations to Dr. Eden, and her team of very inspiring and inspired men and women who make up the Department of Radiological Sciences. I welcome everyone to this session, and I hope everyone will learn from today's activity. We are not alone in struggling with diagnosing our stroke patients or other patients with neurological conditions. But definitely with these steps we are taking, we will be better equipped and more confident in doing so. So I wish everyone a good morning and congratulations again to our Department of Radiological Sciences. Have a good day, everyone. Enjoy the institutional conference. Thank you.
Thank you, Dr. Arcide, for that warm welcome.
Now, it is our honor to call on the chairperson of the Department of Radiological Sciences, Dr. Eden Go Santos, to introduce our speaker for today.
Good morning, esteemed colleagues. As we prepare to establish the National Brain and Spine Center, ensuring our expertise in stroke management is paramount. Today's lecture, Stroke Imaging, serves as a pivotal foundation for this endeavor. It is with great pleasure that I introduce our distinguished speaker for today's conference, Dr. Mario Lorenzo C. Coyagkeng, a graduate of Ateneo School of Medicine and Public Health, bring a wealth of expertise on this gathering. Dr. Coyagkeng's impressive journey includes serving as a chief resident in radiology at QMMC and completing fellowships in both ultrasound and CT/MRI. His dedication in advancing medical imaging is very evident. Today's Dr. Coyagkeng will share his insights on the crucial topic of important aspect of stroke imaging, a detailed look at CT scoring in acute stroke. His lecture promises shed a light on the vital role of imaging in stroke diagnosis. The focus on CT scoring will empower us to assess stroke severity accurately and tailor interventions for optimal patient's outcome. Please join me in extending a warm welcome to Dr. Mario Lorenzo C. Coyagkeng.
And now, without further ado, we will now be starting with the lecture.
We will be playing a recorded video of the lecture, but Dr. Kuya Kang will be available for any questions later. Again, you may write your questions in the chat box for the open forum afterwards.
Good morning. My name is Dr. Mario Keng from the Department of Radiological Sciences, and I'm here to tell you about the important aspects of stroke imaging, a detailed look at CT scoring in acute ischemic stroke. As a disclaimer, some of my slides are credited to Dr. Joseph Mars Baluyat, as I have adapted some of his and incorporated it into my report. So without further ado, let us just talk about the brain. So a normal brain works by emitting electric signals from the brain and into the end organs in order for our bodies to function. It thrives because our brains are supplied with energy, namely glucose and oxygen. And it is distributed in this parenchyma or the brain tissue via a vascular network. This vascular network comes from what we call the internal carotid artery and the vertebral arteries, and these form what we call the circle of Willis. This is the circle of Willis. As you can see here, you have the internal carotid arteries supplying the anterior circulation, giving off branches to your anterior cerebral artery, as well as your posterior communicating artery. And eventually, these will branch off to give off your middle cerebral artery, and which is the major vascular territory of our brain. You will also see the anterior communicating artery supplying or bridging rather, which is why it's called the communicating artery, bridging but both sides of the frontal lobes. And posteriorly, your brain is supplied via the vertebral arteries. You have right and left vertebral artery, and these combine in order to form your basilar artery. Your basilar artery will give off supplies to your brain stem, and as it goes superiorly or to the upper part of the brain, it will supply the posterior cerebral cortex. So it is important for us to note that through this circle of Willis, our brains are able to get their source of nutrition and be able to thrive. So what happens if our brain does not get the proper uh, nutrition and the proper uh, sources of energy? Well, most of the time, this occurs through vascular occlusion. Your vascular occlusion will produce numerous mechanisms that will harm the brain. First is the failure of your what you call the sodium potassium pump, and it's mainly due to the decreased ATP from your glucose. And this will cause what we call cytotoxic edema. It simply means that the neurons or the brain cells tend to swell up, no? And therefore they are prone to cell death. And part of what happens in vascular occlusion is what we call the glutamate receptor activation, wherein you activate calcium dependent enzymes and produce inflammation and apoptosis, which is cell death. Also, when you have vascular occlusion, you also sustain hypoxic damage to the endothelium, production of your inflammatory molecules, and damages the basal lamina and therefore disrupts your blood-brain barrier. Basically, all of this will contribute to damage to your brain parenchyma, and therefore later on it's harder to regain some of the functions that we have. So in order to evaluate this phenomena, the phenomena of stroke, it is recommended to undergo imaging. So what imaging is usually prudent to do when stroke is suspected? So as an initial workup recommended by the American College of Radiology, it is appropriate to either use an initial non-contrast CT scan or an MRI. So in our institution, we use the non-contrast CT scan, and it actually provides a lot of information when it comes to stroke. Um, so actually, no, this is the core of our talk this morning, because in order to do what we call the CT scoring, we use a non-contrast CT scan. Okay. So how does stroke appear on CT scan? So usually the manifestations in imaging can manifest in the first couple of hours, especially within the first 6 hours. No, so let me show you here on the upper image. You can see that the vasculature, specifically the middle cerebral artery, becomes very bright. That's because, or what we call the dense MCA sign, because of the possibility of a thrombus formation. So when a thrombus is formed on non-contrast CT scan, it appears very bright like this. Okay. Also, what happens in stroke is that on imaging, there is hypodensity of the parenchyma. If you look at the image here in the bottom, you can see that there are hypodense, or rather dark areas of the brain. So normally the brain would appear something like this, but on imaging, it becomes something like this. You can see the sulci or the linings of the along the brain. It is mainly because of edema. So remember a few slides ago, I mentioned that cytotoxic edema occurs. in the neurons, and it manifests in imaging this way. And because of this hypodensity, there is blurring of your gray-white matter interface. So normally it appears something like this. So you can see that the gray matter here is very visible, and that there are areas of the white matter will appear slightly darker, no? But in this case, the one in the image here in the bottom, you cannot see that delineation anymore. So it's important for us to relate to our friends in neurology that we are seeing a hypodensity in order to report a possible infarct, especially acute infarcts. No, so it's also important to tell our friends in neurology what the extent is, because if there is more than one-third involvement of your MCA territory or your middle cerebral artery territory, there is high risk of hemorrhage. Okay? It's important for us to take note so that we won't be able to contribute to these numbers, no? Kasi as of last year, as of 2022, our incidence rate and the prevalence rates of stroke have increased to these numbers. Okay, so it's important for us to talk about stroke as well as timing, because as you know, time is brain. So once we detect the stroke via the non-contrast CT scan, we determine the size of the infarct or the edematous portion of the brain, and our friends from neurology will decide if a patient can undergo thrombolysis. So by thrombolysis simply means if there is a thrombus blocking the vascular flow to the brain, thrombolysis will make sure that that thrombus, the one blocking the pathway, will disappear, so that the brain will get reperfused with blood again. Okay. So the problem with interpreting infarcts is that sometimes there is difficulty in recognizing as well as quantification. So in terms of relaying the size of the infarct, there's also inter-observer variability and lack of inter-observer correlation. So what does this mean? It means that what I deem as hypodense may not be hypodense to other people. What I will deem as an acute infarct might not be for other people. So in order to address this, the aspects or TT aspects or Alberta Stroke Program Early Computed Tomographic Score, kaya aspects yung title ng ating presentation this morning, is to standardize CT examination with grading system. So we can assess the early ischemic changes which occurs less than 3 hours from the time that the neurologic deficit occurs. No? So it's a 10-point quantitative CT scan score, and usually the aspects will cover their middle cerebral artery. No? Later on, we'll delve a bit into the posterior circulation. But for now, we'll talk about the aspects, because when the aspects scoring was formed, it was really addressed for the middle cerebral artery territory. So in order to read or interpret images, you first have to assess if the images acquired are adequate for interpretation. So how do we do this? So important things to take note for aspects is we interpret the score using your H-shell images, ibig sabihin cross-sectional, and using a 4 to 5 millimeter slice thickness. And in order to qualify as ischemic changes, the hypodense regions must be seen in 2 consecutive slices. So for example, at this level, the basal ganglia area, you can see that there's a hypodense area. If immediately below there is still the hypodense region, then you count it as early ischemic change. Now, if right below this image, you can see that the hypodense area is gone, then you do not qualify that hypodense area as ischemic change. No? Okay. So why should we score in aspects? So as I've mentioned earlier, it is it is good in predicting hemorrhages because larger strokes tend to hemorrhage because like I said, as you see as you've seen in our flow chart a while ago, there is the blood brain barrier gets messed up. Therefore, there's higher risk for hemorrhages if there's a larger area affected. No? So it is also a good predictor for functional outcomes. And I think for me, this is very important. No? So uh, we need to be able to communicate from one department to another. So if your radiologist say a CT aspect score like this, our friends from Neuro can can easily agree or maybe disagree with us, and and in in standardizing the scoring system, uh, it's easy to understand each other. Okay, so therefore, mas we can give better care to our patient. Okay, okay. So how do we score? So we score using the by uh, by looking at the basal ganglionic region, which are these structures right here: your caudate nucleus, your lentiform nucleus, your internal capsule, and the supraganglionic region, which is at the level of the lateral ventricles. No, uh, so basically there is 1 point given for each area, and you subtract it from a total score of 10. Okay, so that's how you score. So for example, so we'll go to an example later now. So it's important to take note of the scoring because uh, if you have a score of less than 7, then there is a higher risk of hemorrhage and it is associated with poor outcomes. So if you look at this chart right here, if I say that the patient has, for example, an aspect score of 8, so that patient has a higher probability of outcome. Okay, so if I have a lower baseline aspects, then that probability of a good outcome becomes lower. Okay, so 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 please take note of the lucky number 7. So that's how I remember it. So if you have a lucky number 7 score and above, then you have a better outcome. Okay? So if you have a score of aspects of 6 to 10, based on based on previous studies, 50% of the patients will have independent functional outcomes. And look here, if you have a 3 to 5 score, that percentage dips very gravely, no? So it becomes from 15, it becomes 15. So reporting your CT scoring is very important. Okay. So take here, for example. For example, we have a 60-year-old patient coming into the ER with left-sided weakness. Okay, so as I've mentioned earlier, look hypodense areas here in your right frontal and your parietal lobes. Okay, and at the ganglionic area, you have hypodense regions here at the frontal opercular region, as well as your temporal lobe. Okay. Also take note there is hypodensity along your insular lobe. Your basal ganglia is okay. So caudate nucleus is okay. Your lentiform nucleus is okay. Your internal capsule is also okay here. Okay. So as you can see, two consecutive images. So this study is adequate for interpretation and for scoring. Okay. So okay, that's your insular lobe. That's your frontal opercular region. You have your anterior temporal lobe, posterior temporal lobe, and you have your anterior, middle, and posterior cortex along the MCE territory. Okay, so let's score. Okay, so you have, like I said earlier, from a score of 10, you subtract each point. So you have your insula, that's 1 point, 1 point for M1 here, 1 point for M2, which is the green here, 1 point for M3. Okay, and then yung 4, 5, 6 is directly superior to these ones. So 1 point for M4, 1 point for M5, and 1 point for M6. So that's a total of 7 points to subtract from 10, and therefore this patient has a CT aspect score of 3. What does this mean? The patient is high risk for hemorrhage, and the patient will have a poor functional outcome. So it's also useful for giving a prognosis to the patient and their family. So we can easily temper their expectations as well. Okay. So the use of aspect scoring in management is also documented well. No? So if you have a persistent deficit and then you have a defined time window, usually again within 3 hours, and you have a high CT aspect score. If remember lucky 7. So if you have a CT aspect score higher than 7, then IV thrombolysis using your RTPA is considered, no? So kapag 4 to 9 hours, there are also studies that say that you can use it, but there are very few studies, and these studies will actually recommend advanced neuroimaging techniques. Now, so far, our machines are capable of doing so, but uh, it will still need some time kasi we need to study it more, at least when it comes to the machine level, no? So the technique of acquiring. So eventually down the road we can do CT perfusion or MR perfusion, but that is for a different topic and a later time. Okay. Okay. So if you look at here, this study shows you that if you have higher aspect scoring, there's also higher benefit of using your IV thrombolysis, no, and it will reduce to mortality. Will reduce the mortality to our patient, no. Whereas if it is moderate, IV RTPA may still be beneficial, but the mortality may not. The mortality rate is not significantly affected, no. Whereas if you have low aspect score, usually involve infarcts involving large volumes, there's no benefit of IV RTPA at that time, no. Okay. So we've talked about the anterior circulation. Now let's talk about the posterior circulation. So again, from a total of 10 points, you subtract each component from a total score of 10. So if you look here, if you have a thalamic involvement, you subtract 1 from 10. Occipital lobe, you subtract 1 from 10 as well. For the midbrain and the pons, that's 2 points each, no? And your cerebellum is only 1 point each side, okay? So sa anterior circulation, lucky 7, right? Posterior circulation, usually a score of greater than 8. So 8, basically sa posterior circulation, 8 is great, okay? So usually it will lead to a good functional outcome. And your modified Rankin scale, so that is a scale that we use to predict if babalik ka sa functional activity within a span of 90 days after the incident, no? So if it is less than 3, so that basically the lesser the modified Rankin scale, the better. The higher it is, the worse the outcome is. So you can see here that there is good outcome, okay? And that if you have a less than 8, so yung pag less than 8, no, from 52% na good score ka sa pag 8 and above, pag less than 8, nagiging 4% na lang siya. Okay. So it dips significantly, no? So it is also, so basically it's also a tale of caution then for the radiologists and the neurologists, no, na kasi 7 ang the threshold of 7 and 8, medyo malaki yung agwat nung functional, yung percentage ng good functional outcome. So we also have to be cautious in reporting the aspect scoring. Okay, so let's try and apply. Okay, so case number 1. So you can see that there is a hypodensity in the posterior limb of the left internal capsule right here. Okay, excuse me. The other MCA territories are remarkable. So internal capsule is only 1 point. Therefore, if you subtract it from a total CT aspect score of 10, it becomes CT aspects score of 9. Okay, so can we do IVR-TPA? Probably yes, especially if we catch this within the 3-hour period and with a good NIH stroke scale. So yun yung scale na ginagamit ng mga friends natin from neurology. Okay, so case number 2. So you can see here that there are hypodense regions in the right posterior temporal lobe, usually M3. So this one, M3, and then you have your M5 here and your M6. So that's a total of 3 points. Let's subtract it from 10. So 10 minus 3 is 7. CT aspect 7. So lucky 7. Then this patient will have relatively good functional outcome and is a good candidate for IV thrombolysis. Again, dependent on timing on NIHSS. So do not take the CT aspect scoring as it is. You also have to correlate it clinically, kailan yung timing ng stroke and kung how the patient is clinically based on your stroke scale. So yeah, you also have to keep that in mind. Okay, so here, let's use posterior PC aspects, yung posterior circulation. So you can see that there are hypodense areas in the right occipital lobe. Okay, this one. And you also have hypodense areas in the right thalamus here. Okay, so -2, 1 point for the occipital lobe and 1 point for the right thalamus. Subtracted from a score of 10, you get PC aspect score of 8. So 8 is great. So good. This patient will have a good functional outcome. Okay. So case 4, you can see that there are hypodense areas in the frontal operculum right here. That's your M1. You have your hypodense regions here in the anterior temporal lobe, which is your M2. Your M3, which is your part of your posterior temporal lobe. And you have the insular cortical involvement. So dun pa lang, we have a total score of 4. Okay, let's add M4 segment right here, M5 segment, and M6. So 4 plus 3, that's 7. So 10 minus 7, you get a CT aspect score of 3. This patient will relatively have poor functional outcome. So thank you for your time and for listening. I hope that kahit papano I've shed some light on what we do to be able to help the patient when it comes to stroke. Thank you very much, and the floor is now open for questions.
Thank you very much, Dr. Kuyageng, for that very insightful lecture.
So now we open the floor for any questions from the audience. Again, if you have a question, please feel free to type it in the chat box.
Okay, free to kick off our open forum. I actually received a direct message from one of our participants. They would like to ask, what are the limitations of aspect scoring system in assessing ischemic stroke?
Hello? Clear naman yung microphone?
Yes, po,
Yeah,
sir.
okay. So actually for CT aspect scoring, one of its limitations is actually one, again, like I said earlier, if the images are adequate, no? So if the images are not following the 4 to 5 millimeter cuts, or there are significant motion artifacts that will hinder interpretation, then of course that is automatically a limitation. But I think that's more on the technical side, no? But on a practicality level, no, one of the weaknesses of CT aspects, and I guess for the non-contra CT in general, no, is that it cannot tell you uh, the we're medyo papasok tayo ng konti sa perfusion, no, is the penumbra. So the penumbra is actually the tissue you can still save, no, when there is an infarct. Okay, so kapag non-contra CT, it's hard to delineate that penumbra, no? So ito na yung dito na pumapasok yung advanced neuroimaging techniques. And this usually occurs within the time window of 4.5 hours to 9 hours, no? In fact, there is a trial called the Extend trial that will address this matter, no? So yeah. So those are some of the so timing, acquisition. So these are few but the common limitations of CT aspect.
Timing, precision.
Hello?
Thank you, Dr. Kuyageng. At this point, we would also like to acknowledge the presence of a few of the staff from the Culion Sanitarium and General Hospital. They are as part of our knowledge sharing efforts with the GIDA DOH hospitals. Okay, thank you for
Hello?
coming.
Yeah.
We have another question po from direct message also. It says, thank you po, doctor, for the lecture. Would just like to clarify, doc, if can aspects be used with other imaging modalities besides CT, such as, for example, MRI po?
MR,
Thank you po,
yeah.
doc.
So the direct answer to this question is yes, you can. In fact, the papers that I've presented, especially the ones done in 2021, 2022, you can use this CT aspect, the aspect scoring also for MR. Although yun nga, with MR kasi you have other techniques that are probably more advanced that you can use. So there's the DWI flare mismatch. So usually yun ang mas ginagamit. That's why parang na niya yung aspect scoring in that manner, no? So we have the DWI flare mismatch. So mas ginagamit siya for strokes rather than CT aspects, because the DWI flare mismatch will also tell you if there is penumbra to save. Okay, so yeah. So to answer your question, yes, you can, but there are better techniques to use in MRI.
Thank you po, sir. Actually, they have one more additional question po. In what scenarios po, if ever, might aspects not be the ideal tool for evaluating ischemic stroke?
So
Thank
for
you po.
ischemic stroke, usually maganda yung aspects within the time frame window that I mentioned earlier, 3 hours. Sometimes you can use it 4.5 to 9 hours, but again, advanced neuroimaging technique is recommended. But beyond that, wala na kasing added benefit yung CT aspects, no? Kasi whether or not may maganda yung score niya sa CT aspect scoring, the timing may hinder the neurologist from administering IV thrombolysis. So yun po. But of course, I think a better person to answer that question is a neurologist kasi it's really more on the management side na. So I'm just telling you kasi we also take into consideration as radiologists kung ano yung next step ni neuro. So I guess that's also the situation wherein it is not useful, no? And also for kunyari, old infarcts or subacute infarcts, usually not recommended siya.
Thank you po, sir.
Dr. Reside is raising their hand. I think there is something that she would like to say.
Yes, Dr.
Yes, I have a question
Madam.
for our resource speaker. Good morning, Dr. Kuyegkeng.
Morning po, ma'am.
Very, very informative session for today. And of course, this is one of those, I hope, that will kick off a lot of other learning opportunities as we gear up also and enhance our capability as a brain and spine center. So my concern lang is, a lot of the technical stuff, you have already covered. But in summary, I just like for you to summarize all of the ideal scenario, or what is the ideal situation wherein you have a stroke patient coming in and scored as per your as per the system that you have presented with the best outcome possible. And is that within the first 24 hours? What kind of CT should be used for these patients? What are the characteristics of the patient that will make a score a very promising score in terms of prognosis? No, can you summarize that for us? Because I think that will be the main learning points from this morning.
All right. Sige po, Doctor. Thank you
Thank
for
you.
that question. Okay, so again, ideal scenario would be something like this, no? A patient suffers a neurologic deficit, can be in the form of dizziness, can be in the form of a seizure, can be in the form of weakness in one part of the body. That usually occurs within a time span. Ideally, to apply this method, ideally within 3 hours. No? So 3 hours from the stroke. So usually, this is when we do our brain attack. If a lot of you guys will remember, no? So we do yung brain attack team. No? So usually, within that 3 hours, the patient will be assessed by neurology and usually is referred to our service to first check for a non-contrast enhanced CT scan. So from there, we determine if there is an infarct, no? So a stroke, to be more specific, an ischemic stroke, no? Kasi pag hemorrhagic stroke, again, that is a different topic po. So for an ischemic stroke, usually po, we will determine it, and then usually we talk with the neurologist already kung ano yung CT aspect scoring ng patient, and if usually dun kami nagkakaroon ng konting discussion, no? So as to what CT aspect scoring, and then if pasok po doon sa time frame of the IV thrombolysis, and then they will administer. Now, when we relay the scoring, usually we give the locations of the infarct, and then we give a score. Again, for the aspect scoring, for the anterior circulation or the middle cerebral artery territory, no, lucky 7, and then for the posterior circulation is 8 is great. So if more than 7 for the MCA territory, then it is the patient will have a good outcome. uh, especially if there is intervention done by our neuro friends. And for the posterior circulation, if it is greater than 8, we can uh, then we can predict that there is a good functional outcome, provided that they are given the proper intervention within that time frame period. So to remember, no, 3 hours for CT aspects to be very useful in our setting. If it's anterior circulation, greater than 7, lucky 7 is good. And for the posterior circulation, 8 is great. Okay? So, paano kung hindi siya nagland doon? May use pa ba yung CT aspects? The answer is yes. It can predict hemorrhages kung magbe-bleed yung infarct within the next few days. Also, we can also predict for yung functional outcome after the stroke event. No? So, usually within 90 days, kung ma-predict natin if the patient will have a good functional outcome or a bad functional outcome based on your baseline CT aspects. Okay, I hope that clears it up a bit more, Dr.
Well, in addition lang, just one last
Yes, sir.
concern. Are we looking at specific CT capability here? Because of course, when we're dealing with other hospitals, there can be level 1, level 2 hospitals with scans, but 16 slice. And so, how can they work around this
Yeah,
capability, or is it something that they cannot be expected to do anymore because of the quality of their CTs?
so for the CTs po, Dr. A 16 slice CT scan, which is the standard CT the standard capability of a CT machine nowadays, no. Yun yung pinaka basic na yun can uh, can be useful in doing LCT aspects, and it is very useful. In fact, when during the pandemic, no, when we dedicated the 64 slice for the chest CT scans for the COVID, no, patients, we use the 16 slice quite a bit more often for the suspected stroke patients, and it works well po. And so actually, no, that's why we also chose this topic, no, because CT aspects is very useful uh with with the even with the older generation of CT scans, no. You just need to acquire the proper uh techniques that I've mentioned earlier, which is ano naman po, chine-check naman po yan usually ng radiologist po if okay siya. If hindi, we usually just do a repeat scan just to check if to confirm what we've seen initially.
Thank you. Thank you. Very helpful indeed.
Okay. Thank you, Tona.
Salamat.
Okay, thank you very much for that question, Dr. Fide. At this point, we would like to ask if there are any other questions from our participants for our speaker. Okay, if there are no other questions, we thank everyone for your participation in the open forum. Thank you for that very engaging discussion. And a special thank you again to Dr. Kuyageng for that very informative and very enlightening session.
So we had the privilege today of hearing from an outstanding speaker who shared very valuable and practical insights on important aspects of stroke imaging, which would definitely be useful for all of us.
We would like to call on Dr. Eden Dos Santos to present the Certificate of Appreciation for our speaker.
So this certificate of appreciation presented to Dr. Mario Craig King in recognition to his insightful lecture all important aspects of stroke imaging. Your expertise has significantly contributed to our understanding of this crucial field. Again, thank you to Dr. Mario Quilkin.
Thank you po.
Thank you very much, ma'am. So to formally close our program, we would like to invite Dr. Marco Javier, Executive Officer and MRI Section Head of the Department of Radiological Sciences, to deliver the closing remarks.
The department would like to thank Dr. Mario Quinquing for such an informative lecture. The aspect scoring assessment stands as a very important tool in the management of ischemic stroke. Its ability to provide early accurate detection of brain injury, guide treatment decisions, and predict outcomes is essential. By offering a standardized and consistent approach, aspect scoring enhances communication among healthcare professionals, ensuring that patients receive the best possible care. As we look to the future, the continued integration of aspect scoring into the clinical practice and research will undoubtedly lead to further advancement in stroke treatment. This tool not only supports immediate decision-making, but also contributes to the long-term improvement of patient outcomes, helping us save lives and reduce the devastating impact of stroke. Thank you for recognizing and supporting the essential role of aspect scoring in stroke care. Together, we can continue to make strides in improving the quality of life for those affected by this condition. Thank you.
Thank you for those closing words, Dr. Javier.
And again, thank you everyone for participating in today's event. So as we are now reaching the end of our session, we would just like everyone to turn on their cameras for a group photo. Okay, just waiting for a few more participants. Okay, we'll take the picture na po. 3, 2, 1. Okay, next page po. Again, 3, 2, 1. Thank you very much, everyone.
And as we wrap up today's program, we kindly ask all the participants to complete a quick post quiz. So the quiz will be very brief and should only take a few minutes to complete, which you can access by scanning the QR code on the screen in front of you, or you can follow the link that will be posted in the chat box.
And with that, we formally conclude today's event. Thank you very much, everyone, for being with us today, and we hope you learned a lot.
We hope to see you again in our future programs, mga kawani, and have a great day ahead.
Thank you.